everyone. Good afternoon. Um, Dr. Ren, are you with us? Perfect. Hope everything is great till now, and mostly of the people are joining us, and we're reaching almost 14, maybe more of the audience will join us, and especially our guests from Dr. Ren's side, he will join us shortly. So without further ado, I would really delighted to welcome Dr. Ren today. And Dr. Dennis is a pediatric emergency physician at Children's National and assistant professor at George Washington University. He has a strong advocate of free open access medical education, as stands for FOMED, and hosts the podcasts SGEM, PEDS, and Ready Prep Go. His passion lies in creative science, communication, and knowledge translation. Thank you for taking the time and effort to be with us and sharing your expertise, Dr. Dennis. So the floor is yours.
Right. Thank you very much for having me this afternoon. And it is the morning over here. Give me a couple minutes. Let me just make sure that I have my screen shared. Cool. Can you all see that?
Yep, perfect.
All right. I'm just going to move the chat screen over so I can monitor that as well. Okay. Before we dive too deep into our talk, I do want to encourage you, if you can, please have your cameras on so I can see some faces. And I also don't like getting talked at. I will say that. So there will be sections of this where I will ask for some conversation and some interaction. And so please feel free to feel free to put your thoughts in the chat or, come off mute in that case. All right. So that being said, let's jump in. Is this sepsis? This is one question that we probably have to pause and ask ourselves in the course of every single shift that we work in the emergency department. And sometimes these come from a colleague or a nurse that says, hey, you think this kid is septic? Or sometimes it's just the electronic medical record that we have that triggers sepsis per se. Now, before we dive into the technical details, I'm going to present you 3 cases that are based on kids that I have taken care of in the emergency department. And I want you to think, is this sepsis? So first, we have a 7-year-old girl. She's here with a fever. It's 102 Fahrenheit or 38.9 Celsius. She's got some runny nose for the past 2 days or so. It's not eating that well, but, she still is drinking okay per her mom. On her first exam, she doesn't look super comfortable, but there's no signs of meningitis, and her heart rate is a little bit elevated. You listen to her, examine her, give her a dose of ibuprofen, and you check in on her a little bit later. She is smiling. She is running around the emergency department, and she's feeling much better. Is this sepsis? Second case is a young man. He's 14 years old. He has some medical complexity. He's developmentally delayed. He has a gastrostomy tube that he uses for medications and nutrition. And for the past week or so, his parents are telling me that he's been vomiting a lot. He was seen by his pediatrician. They got some urine that looked like he might have a urinary tract infection, and they had prescribed antibiotics. And unfortunately, the family's so busy with everything else in their life that they didn't have a chance to pick up those antibiotics. And now today, when he's coming in, his family said, well, I think he might have had a fever 2 days ago, but here, no fever. His heart rate is a little bit elevated, though, and he's super thin, but the family says, well, he's always looked kind of that way. His capillary refills 3 to 4 seconds, and his father says maybe, just maybe, he's a little bit more tired than typical. Is this sepsis? And then finally, your last case, EMS is bringing a 9-year-old boy. He's had a fever, cough, runny nose for the past 3 or 4 days. He was also seen by his primary care pediatrician, got diagnosed with a cold. And in the last few days, he's really very, very tired, and he's not eating or drinking well. On arrival, his oxygen saturation on room air immediately drops to the low 80s. He's breathing super, super fast. You listen to him, he's got crackles bilaterally on his lung exam, and his heart rate is really, really high. He is quite tachycardic. His capillary refill is 5 seconds. And as you're examining him, he becomes more difficult to arouse. So you try him on BiPAP, but mental status still continues to decline. Is this sepsis? So that's what we're going to talk about today. We will talk about how the definition of sepsis has evolved, specifically talk about the Phoenix criteria for sepsis, and then we'll talk about the challenges when it comes to the screening tools that we have or what we do in terms of trying to detect sepsis early. So first off, a lot of our data and how we think about sepsis in children is extrapolated from the adult population. Back in 1992, we saw sepsis 1, the first kind of definition that we encountered. And this had SIRS, right? Or that systemic inflammatory response syndrome that was defined by either fever, or you can have hypothermia. You could be tachycardic greater than 90 beats per minute. You could be tachypnic greater than 20 breaths per minute. You had to have some kind of elevated white blood cell count or decreased white blood cell count and some kind of bandemia as well. Based on this definition, sepsis was defined as having those SIRS criteria plus a suspected or confirmed infection. And then severe sepsis, you had sepsis plus end organ dysfunction, elevated lactate, and hypotension. And then finally, in order to qualify as septic shock, you had to have all of those things in severe sepsis, and you didn't respond despite adequate fluid resuscitation. Do people have thoughts of how useful SIRS is when it comes to the pediatric population at all? Feel free to come off mute, type your responses in the chat. Is it useful?
Well, I don't think it's useful as it should be, because I mean, like once the kids are crying, they will got like tachypnic, tachycardic, and these things will mess up the definition.
Thank you, Dr. Mohammed. You nailed it. Yeah, I don't think SIRS, for our purposes in the pediatric population, is particularly useful, right? Like you said, the child could be anxious, the child could be in pain. Depending on age, some children do breathe at greater than 20 breaths per minute. So SIRS to me has always been like, what are we calling this, right? Is this diet sepsis, sepsis 0? Or is it more of like, for our ED purposes, hey, this child is sick and I think there's something wrong with them and I'm definitely not sending this kid home. So let's find a reason to admit. All right. So that was sepsis 1. Moving on to sepsis 2, this is now 2001. Not too many big changes here compared to what we talked about in sepsis 1. They did expand the signs and symptoms of sepsis, so include altered mental status as well. And they also added a staging system. There were more lab criteria that you could use, like inflammatory markers, CRP, procalcitonin, markers of tissue perfusion, more hemodynamic parameters, and markers of organ dysfunction. Now, they did acknowledge, I will say, in this definition, the limitation when it came to applying this in children with the quote, children and neonates maintain higher vascular tone than adults. Therefore, the shock state occurs long before hypotension in children. The staging classification system was the PIRO system, predisposition, insult, infection, response, and organ dysfunction that I'm not going to jump too much into detail about. And then finally, so this was 2001. Finally, in 2005, we have something more for pediatrics specifically, the International Pediatric Sepsis Consensus Conference that modified these definitions based on pediatric age groups and development. So they classified, they set parameters based on whether or not you were a newborn, a neonate, an infant, toddler, preschool, school age, adolescent. And they said to qualify as having SIRS, you needed at least a temperature abnormality or white blood cell abnormality as well. And it just can't be based solely on tachypnea or tachycardia. So we've made a little bit of progress now. Finally, sepsis 3, 3rd edition. We got rid of SIRS and we said, all right, let's get rid of this like severe sepsis business as well, right? And sepsis now is defined as this life-threatening organ dysfunction caused by a dysregulated host response to infection. We also saw that septic shock was defined as a subset of sepsis with now these underlying circulatory metabolic abnormalities that could increase your mortality. They started adding calculations and scoring for organ dysfunction. So this is also where we saw the SOFA score, sequential organ failure assessment. And if you scored 2 or more, that was associated with a mortality of greater than 10%. There was a quick version of this for adults that was based on their mental status, their respiratory rate, their blood pressure, and that would kind of give you a quick bedside clinical score that you can use to identify the patients that would have poor outcomes. But again, this was for adults. So where does that bring us today? Welcome to the Phoenix criteria, now in 2024. So it took us a little bit of time, but this was based on data that was derived from an international multi-center retrospective cohort study that included over 3 million children. These were from high resource and low resource settings, so makes it a little bit more generalizable. Despite all of the things that we talked about that were included in previous sepsis definitions, they kind of tried to make things simple, right? They tried to make it as easy to use as possible. So they focused ultimately on 4 main systems in that sepsis score, and that included respiratory, cardiovascular, coagulation or hematologic, and neurologic. You would get points based on a combination of lab criteria, such as your lactate level, the platelets, INR, D-dimer. But because, again, some of this was derived in lower resource settings, there were clinical criteria as well, right? So that included the mean arterial pressures, it included a GCS, it also included whether or not you had to start a patient on vasopressors. They said that sepsis should be considered for any child with suspected infection and a score of at least 2 points. And you needed at least 1 point in that cardiovascular category to be classified as septic shock. How useful is this for us in the ED? Well, despite how nicely this definition is laid out, there is one part that remains quite subjective, and that is you had to have suspected sepsis. So again, that kind of puts the ball back in our court, right? Like, who's to determine accurately which child has suspected sepsis or not? There's still that fuzzy gray area. Do people use Phoenix criteria to help them screen for sepsis in the ED? How do you think does this work or does this not for us in the ED setting?
Actually not, to be honest. As part of Phoenix criteria, it's not very suitable to be done as a screening tool in the ED. This is my point of experience, to be honest.
Yeah, absolutely. So totally agree with that. And it actually, there's a separate paper from where they describe the Phoenix criteria that specifically says the Phoenix criteria are not to be used as screening tools. So where in the world does that leave us? When we think about the 3 cases that I had presented earlier, the child that has a cold, fever, you give some antipyretic of some sort and looks better and is playful. Does that child have sepsis? Do we like thumbs up, thumbs down? What do we think? You can put your answers in the chat too. That first child. Probably one of the most common kids that we see in the ED all the time, right? Fever, URI, looks better after a dose of antipyretic. Does that kid have sepsis? Not sepsis. Yeah. All right. Now let's think about that third kid. That third kid that I described, the boy that came in, also fever, viral illness for a couple days, diagnosed by his pediatrician, but has oxygen saturations in the low 80s, delayed capillary refill, difficult to arouse. Is that sepsis? You see, we have a probably septic. Yep. Okay, so we got a lot of yeses there. Perfect. And now that child in the middle, that second case we described, he's got some medical complexity. He's thin. He's got a G tube. He might have had a UTI that we haven't really treated with antibiotics, had a fever 2 days ago. He's tachycardic. His capillary refill is maybe borderline. Is that child that's have sepsis? All right, so we have to, the comments made, you have to screen him. So we'll get into that. But that's one thing I want to highlight, right? Like sepsis is a spectrum. And in general, we don't really have trouble recognizing both ends of that spectrum, right? The really well-appearing kid with the fever that is feeling much better after a dose of antipyretic, nobody here is pausing to be like, all right, okay, we might have to do more workup. We are pretty good at recognizing that and saying like, supportive care, hydrated home, you'll be okay. The other end of the spectrum, that kid that's really, really sick, that is not easily arousable, that the SATs are low, that the capillary refill is delayed and is tachypnic and tachycardic, that one's also pretty obvious in the sense that, wow, this kid's really, really sick. Probably sepsis. Nobody's going to blame you for treating that kid aggressively. But it's that middle of the road, that middle of the spectrum, that gray area that is super, super challenging. So let's talk about screening next, right? This is about screening. The comment was made in the chat. You have to screen him. Well, what are you going to do? How do you screen? What does that mean? There's like two big categories of stuff that we do when it comes to sepsis screening. So what are we looking for? Again, feel free to unmute or put your comments in the chat.
Actually, looking towards the vitals, which is the mainstay, and then the clinical, let's say the clinical status of the patient. And plus and minus, we will go with the partial septic in terms of CBC with differentials, blood cultures, procalcitonin, if we are lucky to have it, as well as CRP, in order for us to screen them as a base of sepsis.
Yeah, great. So I think the two criteria that you just described are the physical exam and some of the lab tests, right? And so to me, when I think about these two categories, I almost feel like when we screen for sepsis, we almost have two different screenings. The first one is that physical exam, right? The vital sign abnormality is the overall clinical appearance of that patient, what their mental status is, how they're perfusing. And vital sign abnormalities are tricky, right? They're not specific for sepsis by any means. And so just for example, let's say you have a child who's coming in with an asthma exacerbation. Maybe it's flu season and they have flu and they have the fever as well. So they've already tried a lot of their asthma treatment at home. You're putting them on albuterol in the emergency department. So now you're seeing, well, this child is febrile, his temperature is up from the flu, and his heart rate's up as well because you're giving him albuterol, right? So that's a potential side effect of albuterol. And he's also breathing hard. Is that his asthma exacerbation? Is the constellation of everything sepsis? So it doesn't really, there's nothing that specifically tells us that like, oh, this is sepsis, right? And the other thing is from if we think about just the overall child with a mild viral illness, they can also be tachycardic and tachypnic, right? But that could be because they're anxious or they hate being in the emergency department and they hate seeing doctors. And who's encountered that before? I definitely have, right? And so it's only after you do this physical exam that I would say it's like you're screening one. If you're suspicious, and again, this is subjective, then you move on to screening two, which is your labs. And I think you had mentioned some of the labs that we consider, right? We've talked about white blood cell count, which honestly is not fantastic in kids. We've talked about some of the inflammatory markers like CRP, again, not fantastic. Procalcitonin, I feel like, is grown in popularity recently, especially now we use it so much when we risk stratify the febrile infants. We know that it rises a little bit faster in the setting of bacterial infection. But again, what if this is early, right? What if this is that pre-sepsis where the pediatrician is seeing this kid with the fever and the URI symptoms? How do you predict that that is the kid of all of the children that you see with those symptoms that's going to go on to develop florid sepsis later on? So none of these lab tests are sensitive or specific enough to help you make that determination. The other thing that I hear commonly is blood cultures, right? So if we have high enough suspicion that this child is sepsis, we will get a blood culture. So what percentage of blood cultures are negative? Any idea?
Maybe 60%, most of the cases.
The question was what percentage of blood cultures are negative, or conversely, what percentage are positive?
I mean, maybe 60%, most of them are negative, and maybe 10% will be positive or lesser than 10%.
Yeah, absolutely. Yeah. So the literature that I found said maybe if you're lucky, 20-30% you're positive, but up to 76% of blood cultures in sepsis are negative, right? And that's probably because there are viruses that can land you in like viral sepsis as well. So that's also not fantastic. One other thing, just going back to procalcitonin that I'll mention, is that procalcitonin, for us at least, even though we're a big academic center, the turnaround time for that is a couple of hours. So like if we're lucky, it tends to be average like 3. There are other places in the world, and I don't know how it is at the various sites that you practice. They don't even have procalcitonin, right? They either don't have it or it's a send out test that you'll get the results back 2 days later. Not exactly helpful for you when it comes to making your clinical decision. And even if you're waiting 3-4 hours, if that kid gets sick, and those of us who have seen a child in sepsis, they get sick fast. You do not have those couple hours of time to figure that out and make that decision based on one lab test. So all that being said, you see there's imperfections both in terms of how we screen based on clinical exam. There's also imperfections of how we screen based on laboratory testing alone. So then brings up the question, where do we go? And I don't know if Dr. Yanis Koutralis is on the call now, but a lot of times I go to people much smarter than me to help me prepare for some of these talks. And he is an awesome, awesome teacher and a great sepsis researcher. And he had told me about work that they are doing within the fields of genomics and also artificial intelligence. And so genomics, they are looking for blood biomarkers. Again, this is limits your generalizability, right? Because these are still new tests that show promise, but in terms of widespread implementation is still to be determined. We don't know the turnaround time for how rapidly you're going to get those test results back yet. From an artificial intelligence standpoint, I think one of his projects is actually looking back at many of the notes on patients who were septic and seeing were there things that were documented that we might be able to use artificial intelligence to kind of pull out from that can also help us make that decision. I think if he is here, I'll invite him to share his preliminary results, but I think he has much better sensitivity and specificity than a lot of our current screening tools. But I was here to talk about what are the things that we miss in triage. And with all that being said, I'll be honest with you, maybe that was a little bit of a false sell, because to be honest with you, I'm not sure. It's a hard question to answer, because as we talked about how the definition of sepsis has evolved and the limitations in how we define it, How in the world do you screen for a condition that is not well defined? So with that being said, I want to thank you for your time and joining us this morning. That QR code is a handout with resources, references for the talk that I gave. And with that, I'm going to end this part, and hopefully we're going to have some discussion on things.
Thank you so much, Dr. Dennis, for the great presentation and for the as well for the insightful and engaging talk. Actually, we're waiting for if there's any questions from the audience. Would love to ask or
Yeah, please feel free to ask questions. I think a lot of the enjoyment that I get out of being able to present in a venue like this, also to interact with you all, practicing in a country very different from mine, is that I learn something new all the time. And this is a time that I feel like we should share ideas and brainstorm together.
yeah.
Ultimately, we have the same goal, right? We all want to improve the care of children. So I'd love to hear what you all are doing, where you think your emergency departments, your hospitals are going when it comes to sepsis screening. And I can share some of like the stuff that we do here.
Okay, perfect. I would like to share our expertise from our cluster. Actually, our hospitals in the Kingdom, Saudi Arabia, we are in clusters, like cluster one, cluster two, and cluster three. However, as some of us, we have a lead projects, and one of the lead projects that I'm leading currently in our hospital, which is the code sepsis. So we're dealing the sepsis in our ED as a code. Once the patient arrived in the triage, by the nursing visual triage, they will visualize the patients based on the screening. The screening depends on like the Q-SOFA, but it has been validated by our perspective from senior physicians in our ED. And then we have implement that to our patients actually, or let's say our population. It's group A and group B. Maybe I will share it with you later on to get a big, let's say a big point about it. After that, after the visual triage, the patient will be finished to the triage of physician triage. So the physician triage, he will take a look about the patient. If he's a truly sepsis, as you mentioned, he is lethargic, hypoactive, tachycardic, but it's not a viral thing that we are not afraid of. So after confirmation from the triage physician, the patient will be pushed immediately as CTAS2 or CAT2 to our resus area, and we're dealing with him as a code, a true code. Less than 5 minutes, all the physicians will be bedside, and then they will work harder on the patient by withdrawing labs, giving antibiotics, giving fluids. How by saying that, unfortunately, we are coming up to results that we are giving the patients more antibiotics. By saying this to be fetched from the beginning as a part of a true bacterial sepsis. Most of the cases we're dealing with in our AD, it's mostly viral. It's not to be a bacterial. And thankfully, you have mentioned that very clearly in your presentation, one slide, how you would screen sepsis since it's not very well defined. This is the main goal of our really talk and discussion for today, which is I really love it, but I would love to share our expertise because we would love to learn from each other's what you have been done in US. It's different than the Gulf countries. So I know the challenges are different in different population, but I don't know if you have a screening tool you have implemented or by your experience within the years of pediatric emergency physician, you have went through the sepsis screening tool and you get succeeded with. If so, Dr. Wren, kindly share.
I think you're asking for the holy grail right now of like the best sepsis screening tool. I don't think one exists, right?
Mhm.
I think many of the tools that we use, so for ours, it's built into the electronic medical record. It tends to be triggered by vital sign abnormalities, like you mentioned, right? The temperature, the heart rate, respiratory rate, etc. The flow typically here is that when the patient checks in and they're assessed by our nurse that is out in triage, after those vital signs are entered, then then our electronic medical record triggers this alert, right? This sepsis trigger that says maybe this child has sepsis. And then that triggers the triage nurse to give us a call as the PEM docs to go and actually assess the patient when they're in the room. Now, that being said, you can imagine, especially in the height of cold flu season, winter time, right, when respiratory illnesses are prevalent, temperatures, everybody's having a fever, that actually translates to a lot of calls that I get on the phone that I carry. And that's also bad too, right? Because then you might be in the middle of something. And yes, we're all good at multitasking just by nature of working in the emergency department. But every single time one of those calls comes in, it's like, oh, it's interrupting your train of thought. Did you forget to do something for another patient that you were seeing? So it's a very difficult balance. I think most of the tools that we have emphasize sensitivity, right? Like we really don't want to miss anything. But because of that, there are a lot of false positives. And one thing that I've been wondering, but have not researched, is that do you actually need a senior clinician, an ED PEM doc, to assess every single patient? Because sometimes I'll be honest, I get a call from the nurses and there's no worry in their voice, right? It's like, hey, can you come to triage room 1? This patient triggered sepsis. And I'm like, do they look terrible? They're like, no, I'm going to give them some ibuprofen and I'll send them back to the waiting room. So, and more often than not, that judgment is fine. There's nothing wrong with that kid outside of like that viral illness, right? So we're in some ways we're trying to catch that needle in the haystack, and that is the hard part of how you balance the sensitivity and the specificity of the screening tool that you use. When we actually do have suspicion, we have a tiered system for responding. So we have a sepsis red, and then we have a sepsis yellow, right? And so when you look at the 3 tiers, I can say you have no sepsis. You have sepsis yellow, which is like, you're kind of rubbing me the wrong way, and I think I might need to do some testing and like do further screening for you. And then the sepsis red is like, ooh, man, you are really, really sick. And that means everybody's in that room. We are getting access. We are pushing fluids. We are giving antibiotics and doing everything. And so, again, like, where do you define sepsis? Because I do think that there is a subcategory likely in the sepsis yellow, right? The suspected sepsis part, where if you end up treating, let's say, even if you give a bolus, right? Because let's not talk about antibiotics. Like you said, there's a chunk of sepsis that's viral. If you give a bolus and they look better, is that patient technically septic? Like you did intervene, you did the first part of a sepsis resuscitation. So I think that's also mixed, because there's some people like Dr. Cotralis, when I talked with him, he was like, yeah, I would call that patient septic because you had to give them a fluid bolus, and sure, they got better, but like they were septic. And there's other people that are like, I mean, I don't know, like maybe this kid was just a little bit dehydrated and you gave him some fluids and he felt better. So again, that gray area exists. Whichever one of you manages to find the screening tool with great sensitivity, specificity, please reach out, because I do want to disseminate that widely.
Sure. Perfect. Great answer. I actually have 3 questions. First question, we've seen sepsis definitions evolving over the years. In your review or view, what's the biggest change that has truly impacted how we recognize kids with sepsis in the AD? I think we explored this area very much by our talk, but give us just your opinion in one line.
So again, I think the Phoenix criteria are a big step in the right direction, right? We had such floofy definitions of what sepsis is in the past that I think the Phoenix criteria help us actually now, when we look back retrospectively and we want to do studies, we can actually better define a subset of patients that truly have sepsis based on these criteria, right? Because before, when you think about going back, like maybe I was basing it off of a diagnostic code. Somebody at some point thought this kid was sick enough that they had input the diagnosis of sepsis, but like that's not particularly accurate, right? So part of this is trying to get a definition that we can all kind of be around and agree upon to guide our further research. So I think that's an important step. in terms of the stuff that we do in the ED, I think this is that is the step that we absolutely need in order to start thinking more about how we screen, because we again, we don't have clear criteria. I think it's highly variable, probably based on where I work, where you work. So having that established baseline is important. The other thing that I will say, when I spoke to the authors of the Phoenix criteria, some people gave them a little bit of flack because when you think about we'll just pull out the lactate level, right? I think it's the lactate greater than 5 is what you need to score a point. And there's some people that are like, whoa, like that's actually pretty high lactate. Are you sure we don't want to lower that threshold and catch more kids? But I do think the genius of that part is kind of what we talked about, right? Sepsis, a child with sepsis or a patient with sepsis is sick. They are very, very ill. So having the lab criteria to actually guide us in that direction with like, hey, there's end organ dysfunction, there's stuff like that. I think that's also an important step. But I will be very curious to see in the next 5-10 years what we manage to find, how we can apply that in the ED setting.
I hope so. I hope so to see it as soon as possible in our ED screening. Okay, so the second question was screening tools can be tricky. What practical tips would you give frontline clinicians to catch sepsis early without overcalling it?
This again goes into the fuzziness of it, right? I think take the entirety of the clinical picture into consideration. At the end of the day, we talked about vital signs parameters, we talked about lab parameters, but we treat patients, not numbers, right? So don't base your decision solely on the numbers that are in front of you, because they're not always reliable, and we have to interpret it in the context, right? Just like we talked about the febrile child with influenza that has an asthma exacerbation. That child might not have sepsis, or if they look terrible based on your overall clinical exam, they might have sepsis. But you can't just base it off of like a couple numbers. So rely on your clinical gestalts. I think that's something that with more experience you get better at. But if you're ever in doubt, this is where I feel like you have colleagues, right? And I think we're all pretty collegial and friendly in the emergency department. You're not just one person. If you're kind of like on the fence, I often ask, go to another attending in the emergency department, like, can you just double check my thought process, or like,
Hello, I'm
can you just
sorry. I
take
just
a
want to
bit
ask
and
if this
see
meeting is
whether or
free.
not you agree with what I'm doing? And that's great, right? Two brains often are better than one. And I will say, in the course of talking to Dr. Kutralis, the expert here on sepsis, he told me about a patient where like this is his jam, right? This is what he loves to do. And he saw a patient in the ED that he also initially missed for sepsis. So again, we are not perfect. But
Hey,
until we
Dennis
have better
Ren, I just
tools to
wanted to
help
ask
us,
if this meeting is free.
it is what it is.
Okay, perfect. Any questions from the audience? I think there's someone trying to ask a question for you, Dr. Dennis. Where is he?
Well,
Any,
yes,
any,
hello. I
please.
just wanted to ask if this meeting is for free.
Sorry? Yeah. For sure. Free.
Okay, so you don't have to pay anything.
No.
Okay,
We
I
Yeah,
appreciate
okay,
it.
so because like okay, in the other meetings we have to pay with like Ejakulatverschmierer and yeah. But if it's free, it's really good. Okay, thank you.
Okay, welcome. So any questions from the audience before we continue our questions? Okay. Sounds wonderful, Dr. Bren, regarding the screening tool, which is, I totally agree with you. It's kind of tricky, and we hope that we get, which is, you give us a really a great adviseful practical tip. Last question from the audience. Looking ahead, do you think the real game changer for sepsis detection will come from biomarkers, genomic, or artificial intelligence?
This is sometimes when patients ask me, how long am I going to be staying in the hospital? I will preface this by saying that this is a total guess and this is fortune telling. And this might be a little bit of hedging on my part. I'm going to say everything, right? I think there's great work being done in all of those areas. I think, like many things, potentially what we will find is the combination of things from those respective fields will help us create the best, at that point, version of a screening tool that we have for sepsis. And again, if one of you happens to be the person that does it, please reach out to me. I would love to talk to you and pick your brain.
Oh, okay, perfect. Actually, I'm interested in doing an artificial intelligence, especially in screening of pediatric sepsis, and it's a huge project. Maybe we'll give a talk together with one of your pioneers in sepsis in order to implement that in our EDs. Last and not least, if the audience could take away just one key message about pediatric sepsis recognition and management, what would you want it to be?
Go assess the patient. There is nothing that is going to take the place of your clinical exam, right? And again, I'm going to emphasize, we treat patients, we do not treat numbers. So the screening tools are useful to a certain extent, but you have to place it in the clinical context that you are seeing the patient. I will add one thing as we consider artificial intelligence. So I think we're going to see many, many applications of artificial intelligence in PEM, not just sepsis, right? But the big thing that we need to keep in mind is that a lot of artificial intelligence, just like when we do research, is based on the inputs that you give it. So if there's bad data going in or bad resources that is being trained on, you're going to have really bad outputs. And I think that's one of the limitations that when you think about how some people are trying to go back and look at documentation and notes, right? Unfortunately, I will say we're not fantastic when it comes to documentation, and maybe that's for good or bad, right? We're more focused on like actually saving the patient or trying to keep the flow going in the emergency department. But if we don't have good data that's going in and informing the artificial intelligence models that we're trying to run and teach, then that's going to be also a limitation when it comes to using those tools as well.
Yeah, perfect. So go and assess our patients then. So thank you, Dr. Dennis, for such an insightful, engaging talk. We truly appreciate your time and efforts, and as well your expertise. Wishing you all the best. And thank you so much for your time. Thank you,
All right,
guys.
thank you.
Thank you, guys, and thank you for the audience for their participation. Bye. See you.
Bye-bye.